So Atlas Embryology. So Atlas is C1, of course, that's the top bone in your spine, in the cervical spine of your whole spine. It's made from 3 primary ossification centers. An ossification center is how a bone turns to bone. They are little growth factories made of osteoblasts and such, and they spit out bone, and they turn your cartilaginous bone into a solid bone. Kind of strange setup with Atlas. There's one in each lateral mass, and then there's one in that little short anterior arch of Atlas. And then I know what you're saying. What about that big posterior arch that does not have its own ossification center, which is actually quite strange? That's a great board question, right? Anytime there's something strange like that. And yeah, so there's no primary ossification center in the posterior arch. So what makes the posterior arch then, is the question. Well, the lateral mass ossification centers make the lateral mass, and they make the posterior arch as well. So here we can see, and I'm doing this in Camtasia, so I should be able to use my little pointer here, which is very nice. I can even draw too now. But here's the lateral mass of Atlas. Here's the right lateral mass, left lateral mass. There's the anterior arch. This is an overhead view. And yeah, so here's where the little growth factories, the bone growth factories are. And that's the story. So this posterior arch of Atlas, remember that's the posterior tubercle. What's this called right here? Anterior tubercle. What's that called? Transverse process. What's that hole called? Transverse foramen. What goes in that hole? Vertebral artery, more specific. V3. All right, so the ossification starts to occur about the 7th week of embryologic life, and the right and the left posterior arches form in a anterior to posterior direction, meaning the right and the left sides, because it comes out from the lateral mass. Let's go back to the lateral mass. So the bone starts spitting out like this, and it calcifies backwards like this simultaneously, probably not perfectly even. And then right in the midline here, these two ends stop, and it leaves a little gap here for a while. And sometimes it fuses. Some people it never fuses. Right? And that little gap, which is right here. So the whole atlas is bone except for a little piece right here. Let me see if my drawing tools work. Oops. Let's see. I think they do work. Yeah, so this thing will turn to bone except for a piece right here. So when you take x-rays of a little 2 or 3-year-old, you'll have a gap of bone right here. And it can look a little weird, especially if they've been in an accident. You worry if it's a fracture. So that little gap of bone doesn't fuse until, on average, about the 5th year of life. So kids less than 5 will have a black line on x-ray that's called a radiolucent, is black. That's not spelled right. It's radiolucent line, one word. So you have to differentiate that from a fracture. And then in some patients, that radiolucent line is there throughout life. So that little section in the midline never turns to bone. And when that occurs, it's called agenesis, meaning failure to conform of the posterior arch. Or if it's really just a little gap when there's no bone, it's better called a cleft defect. Okay? So you have to differentiate them from fracture. Now, the terminology is a little confusing for this agenesis of the posterior arch. So look at all these AKAs. I know they should get together, these authors, and get rid of some of these terms, but they don't. So agenesis of the posterior arch agenesis, aplasia of the posterior arch of Atlas, congenital absence of the posterior arch of absence, congenital non-union, and you can read this just as well as I can. Posterior arch cleft defect, or sometimes just cleft defect by itself, or cleft defect of the posterior arch. And then spina bifida, Joachim calls it a spina bifida, which really it is a spina bifida, but he's the only one who seems to do that. So what about cleft defect versus agenesis? So most authors, the ones that I follow anyway, say you should only use cleft defect if there's that little gap that doesn't turn to bone. If the entire posterior arch of atlas doesn't turn to bone, or a big portion of it doesn't turn to bone, that's when you say the term agenesis of the posterior arch, okay? So if it's a little gap in the bone, it's a cleft defect. If the entire or most of the posterior arch doesn't form, it's agenesis. And we talked about Joachim and his spina bifida. So how many people have this cleft defect, or maybe even agenesis of the posterior arch walking around in the population? So the prevalence is about 4% of the population. So it's fairly rare, but it's not crazy rare. It's not like Marfan syndrome. Marfan syndrome prevalence is about 0.01%. You could have a unilateral cleft like I drew, or maybe there's a bilateral cleft. There can be different versions of this thing. Could be the entire posterior arch, could be a piece of the posterior arch. Okay, so here is a CT scan overhead. That looks just like Atlas, doesn't it? What's that thing right there? You guys should know that. You just had the test just now. That's the tip of the dens, or that's the dens of C2. And there's the ring of Atlas, but we can see the anterior arch is nice and white. In fact, it's too white. There's the lateral mass, transverse foramen, and you can see that we have a gap, don't we? And it's not perfectly in the midline. Now, the question is that a fracture or not? So that's a 37-year-old, status post-MVA. What's MVA? Motor vehicle accident. And yeah, they come in your office. They bring their CT from the hospital, and you're getting ready to adjust them. You find some fixations. And you look at this, and the question is that a fracture? Well, it's probably not a fracture. See, it's nice and smooth here. Let me get my tools back on. See how smooth that is? It's nice and smooth. It's not jaggedy, right? If the ends are kind of jaggedy looking, that's one way to tell a fracture. And you'll learn that in the radiology program here. What's the space called right here? Where my laser is. Good. Anterior dens interval, or the atlantodens interval, ADI space. What's that number? You should always remember. Should never be greater than 3 millimeters. I can tell this has been going on for a while because the anterior arch of Atlas is too white. So the forces of the head, the axial load of the head and gravity pushing down has, this is called stress shielding. It's taking too much of the force of the head and gravity is passing through this part. And this is spared. See how white this is here, or see how radiolucent this is. It's not nearly as white as that. So, all right, so everything I just said, so that is a cleft defect, you could call that. You shouldn't really call that agenesis. I mean, technically it's agenesis, but it's just a little failure, most of the arch forms, so it's best called a cleft defect. And there's the stress shielding, everything I just said. Right, what do you think of this? And here's the first question. You should get this right. You just had the test on this. Is this a S to I view of Atlas or I to S view of Atlas? Good. Remember the little Ant-Man's helicopter landing pad? Ant-Man's helicopter could land right there. Remember, from an S to I view, these would be very concave. It would be hard to land a helicopter there. So this is the I to S view. But the point is, look at that. We have a nice cleft defect in this specimen. Good. All right, now check out this one. 42-year-old comes in your office, was in the hospital, got a CT scan, brings the disc, wants you to treat him for chronic headaches and neck pain. What do you think? What do you see? Oh, what about the curve? We'll do a little radiographic analysis. Well, the curve is lost, right? It should be a, what's the name of that? Should be a lordotic curve. That's not a lordotic curve. It's quite straight here. Probably muscle spasm, maybe from the accident. There's the cut line. So the cut line is going through, there's the anterior arch of Atlas. going through the dens. There's the anterior arch of atlas. Looks pretty white too, doesn't it? There's the dens. Uh-oh, what's going on here? Where's the posterior arch? Right, this cut should be right through the posterior arch. Right, posterior arch should be, in fact, you can kind of see a cartilaginous outline of it. It should be like right about in here. Spinal cord would be right here. It's gone. Right? So this, what would you call this? Cleft defect? No, this is real agenesis. Would you adjust this person? No way. No way would you adjust them. There's probably some cartilage in here, but you don't know. I mean, you don't know what it looks like. So don't touch this person with a 10-foot pole. You can do some heat and therapy on them, physical therapy or physiotherapy. So what's this? Good, I heard somebody say it. CT. More specific, though. What kind of CT is it? Well, there's the spinal cord. How come we can see the cerebrospinal fluid? So this is not a regular CT, is it? And good, I heard somebody say, what's that? Oh, we got compression of the spinal cord, right? Looks like a disc protrusion or bulge. You can't really tell from one slice. This is a CT myelogram, so this is all contrast that was injected, mixed in with the cerebrospinal fluid. Very nice. The point is, there's a cut line. You can see the anterior arch. You can see the posterior arch. Now, what about this specimen? And then notice here, notice that you've put a dot here. There's C2. There should be the kind of the posterior or the lamina here. Spinous process of C2 is right here, right? And you should be able to do that as well, kind of draw a line, anterior arch, posterior arch. If we draw a line here, there's nothing, right? We can still put these two together. So that's the property of C2. There's the dens. So yeah, another one. We're missing the arch. See how that works? And if we put the real bones side by side here, we can see. It's a lateral view of atlas and axis. There's axis here, there's atlas. Anterior tubercle, posterior arch. And you can clearly see there's nothing here. So that's agenesis of the posterior arch. Right? No assimilation of occiput noted. What in the heck does that mean? We're going to get into that in a minute. Because sometimes it just doesn't form, but sometimes it forms and it's up here on occiput. The posterior arch is stuck to occiput. Sometimes the anterior arch is stuck to occiput. So who cares about this agenesis of the posterior arch? Well, first of all, if it's agenesis of the posterior arch, they're not going to be that stable. You should not adjust them. But there are some important associations. And in and of themselves, this agenesis is not painful. So it's usually completely asymptomatic. But there are some associations that we worry about. People with agenesis of the posterior arch, they also have these congenital defects, blocked vertebrae, Klippel-Feil syndrome. Central stenosis can be quite severe sometimes. And then one called Arnold-Chiari malformation, or sometimes they drop the Arnold and call it Chiari malformation. We'll talk about that one tomorrow. I'm not going to get to that now. Although tomorrow's our last lecture, I might have to cut that out. But we'll see. Some of these have neurological sequelae with them, especially Chiari malformation. And that occurs when and you don't know this, you haven't studied the brain yet, but part of the cerebellum, called the cerebellar tonsils, can actually protrude through the foramen magnum and cause all sorts of trouble. So always do a careful examination in patients with agenesis of the posterior arch. It's not so much because of the cleft defect or the agenesis of the arch, but it's those darn associations that can cause trouble, especially Arnold-Chiari malformation, which we'll look at. Now let's talk about that assimilation of C1 I said. Oftentimes it's called occipitalization of C1. Kind of like sacralization, right? We talked about that way back in week 1. sacralization. So let's look at this kind of weirdness here. So here's another, the CT scan, a mid-sagittal cut. And what do you make of this? Well, here's C2. And you can clearly see the dents here. Where's the anterior arch? Where's the posterior arch? I mean, that's supposed to be in here. Well, they're gone. They're not gone in this case. Now, you haven't seen enough foramen magnum to know, but those of you who are familiar with radiology will say, what in the world is going on with a foramen magnum? This is not supposed to be here, right? That's actually atlas, the anterior arch of atlas, and it's fused to the to part of the foramen magnum here. And this, from about all of this, that's the posterior arch of atlas, which is also fused to the foramen magnum here. Okay, that's the clivus actually, but don't worry about that. All right, so some weirdness, right? And that's congenital from birth. Differential diagnoses, agenesis of the posterior arch. Sometimes you can get cancer that's invaded atlas, and it's eaten the bone. If it's osteolytic cancer, it's eaten the bone away. So you have to be careful to make sure it's not cancer. Or you can get a type of bone tumor called an aneurysmal bone cyst. And that can make the bone really hard to see and thin out the bone. You learn about those when you go through the radiology program. And again, here's the normal setup. What was this called again? This isn't completely normal. What's that? That's not supposed to be there, is it? Good. That's a posterior ponticle. What is it? It's calcification of the posterior lanceolate occipital membrane. V3, the vertebral artery, passes right through here, right? This side's normal. There's nothing here. But there's a, what's that tunnel called? Foramen arcuole or arcuate foramen. Good. But see, we have a nice posterior arch here, right? There's a posterior tubercle. And yeah, what's that called right here? Groove for the vertebral artery. Good. All right, so with that in mind, this is a 3D CT reconstruction. What do you make of this patient? Well, we can see the dens. Go back to this view. Well, we're kind of coming overhead here, but this should be, the view should be blocked by the posterior arch of atlas. Right? Posterior arch of atlas should be coming like right across here. And where is the posterior arch of atlas? Do you see it? There it is. There's the transverse process of atlas, lateral mass of atlas. But the posterior arch on the right here, the right posterior arch is welded to the occiput. And there is the weird looking left posterior arch of atlas, which is kind of a little bit welded to the occiput, the foramen magnum region, but kind of sticking down. And there's kind of a weird looking transverse process here. Yeah, so this is not a genesis of the posterior arch. This is assimilation or occipitalization of C1. See how that works? Good. I drew it in, demonstrated my amazing Photoshop skills. All right, so that's enough about that. Let's just talk about a little neurology here. C1, it's always kind of a weird area when it comes to nerves. The C1 spinal nerve doesn't pass through any foramen or through any neural foramen or IVF, like most spinal nerve does. So there's the board question. There is no IVF between occiput and C1. That's weird, right? C2 and C3 have one. C1 and C2 have one, but not C1 and occiput. There's no hole. So where does the C1 spinal nerve leave then? And the nerve roots leave. It just runs right over the superior anterior surface of the posterior arch of atlas. which is weird. In fact, it splits. It goes right between the vertebral artery and the posterior arch. I'll show you a picture in a second. And then it splits as the spinal nerve splits into a anterior and posterior ramus. Usually, the C1 can be quite anomalous. It typically splits into anterior and posterior arch. That posterior arch, that's very interesting. That's the suboccipital nerve, and that actually has some motor fiber in it, right? Because posterior branches usually are pure sensory, but this one is actually the suboccipital nerve, and it goes and supplies the suboccipital triangle. So that's kind of weird. Right, so here's the overhead view. What's that ligament called that's so important? Transverse ligament of Atlas. What's that? That's the dens. And yeah, so there's V3, the vertebral artery coming out. There it pierces the dura, goes interthecally and becomes V4 here. But you can see it sits right over the top of basically the spinal nerve, C1 spinal nerve, and that splits into a posterior ramus and a anterior ramus, aka dorsal ramus, aka ventral ramus here. And yeah, so that's kind of a weird setup. Here's a surgical drawing of somebody getting a fusion of C1 and C2 together, pedicle screw in the lateral mass there. But picture's pretty cool. There's the posterior sensory root. And yeah, and in this case, there's no dorsal root ganglia. How can that be? Right, there's the dorsal root ganglia on this posterior root. Well, sometimes C1 doesn't even have a dorsal root ganglia. So that's strange. All right. So what about the ventral root? The ventral root, no, it doesn't supply the suboccipital triangle. It's motor as well. It makes up part of the cervical plexus and the ansa cervicalis, which you studied in Gross 1 anatomy. The ansa cervicalis is made from the ventral rami of C1, C2, and C3, sometimes C4. What does the ansa cervicalis do? It supplies the strap muscles, aka infrahyoid muscles. Who are they? This is all Gross 1 stuff, I believe, or is it Gross 2? No, it's Gross 1 stuff. Omohyoid, sternohyoid, thyrohyoid, and sternothyroid. So those are the strap muscles. In fact, thyrohyoid is pure C1 innervation. But that's from the ventral ramus. Right, so we've seen this in the cadavers, right? We've seen that loop, and we've seen little twigs coming off and going to all the strap muscles. And yeah, that's the ansa cervicalis right there. It's usually made by C1, 2, and C3. Let's see if that's true. Well, here's C1, and this is an A to P view. That's the anterior ramus. So that's the main chute. Some of the hypoglossal nerves, some of the fibers hitchhike on this. They don't really do anything. They don't innervate the strap muscles. But they do hitchhike. Some of the fibers from the hypoglossal nerve hitchhike on this. Let's see C2 now. There's C2. So C2 is supplying it, and here comes C3. And C4 is not really connecting to it in this specimen. Good. What else do we want to say? Again, the posterior sensory roots can be really anomalous. In fact, they're super thin. They do give rise to and we're talking about the rootlets. So those are the ones that come right off the spinal cord level, right? The rootlets coalesce into a posterior root, which coalesces into a spinal nerve. So they're very anomalous. And they can anastomose with C2, which is weird, right? Usually they're pure. They go to form their own thing, but some of the nerve roots actually connect to the C2 nerve roots about 61% of the time, which is very strange. Chiari, we better do this. We're going to do Chiari malformation tomorrow morning. Chiari malformations can irritate these nerve roots and cause all sorts of trouble. And typical irritation of C1 causes problems, pain, around the orbits of the eyes, like you have this weird pain around your eyes, on your forehead, and the top of your head. So some really weird places. Yeah, we better do Arnold Chiari tomorrow. Just some fun facts about the C1 nerve root. We already said that dorsal root ganglion may be absent. In the drawing we looked at, it was completely absent. The posterior ramus is suboccipital nerve, which is motor, which is very strange. And sometimes that posterior ramus doesn't split into a medial branch or lateral branch, like most do. And posterior ramus can loop superiorly to supply motor function to the suboccipital nerve, which is weird because